Hello, everyone. I'm Ron Rolfing, your host of the ACAP Preferred Vendor Education Series, and I'd like to welcome you to our latest session presented by Pop Healthcare and MCARA. Our discussion today is with Carrie Musselman, VP of Pharmacy Care Solutions at MCARA Health, and Tiffany Pack, Vice President of Marketing and Communications with Pop Healthcare, and Tiffany will be moderating today. And they will be discussing the paths to improve patient outcomes, health equity, and return on investment, all lead through comprehensive medication management. But before we get things started, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines. And these guidelines can be viewed on our website. We will be recording today's call, and we'll post the slide deck and recording on our website by tomorrow morning. And the link to these items could be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. You can also post a note or even an RFP on the Preferred Vendor Connection portal. And of course, during today's session, you can ask a question at any time by clicking the Q&A icon on your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now I'll pass it over to Carrie and Tiffany.
Great, thank you, Ron. Hello, and welcome everyone to today's webinar on comprehensive medication management. Before we get started, I would be absolutely remiss if I did not say Happy National Pharmacist Day. We picked a good topic, I think, for a day like this. So I'm Tiffany Pack, and I'm VP of Marketing and Communications from MCARA Health and Pop Healthcare. My background is in marketing, healthcare marketing, really for the last 15 to 17 years. But I'm also a bit odd in that I have a master's in public health and have a real passion for health behavior and health education and getting people to do the things that we want them to do to maintain great health. I am super pleased to be here with my colleague, Carrie Musselman. Carrie is a board certified ambulatory care pharmacist. Before she joined MCARA Health, she was pharmacy director and ambulatory care practice medication management for Bon Secours, which is a mouthful, for Bon Secours Mercy Health, and previously held successive roles in pharmacy leadership. She did her residency in community care pharmacy practice at VCU, Virginia Commonwealth University, at their School of Pharmacy, and also did her Doctor of Pharmacy there. For those of you who are basketball fans, it's probably good for you to also know that she did her undergrad at University of Kentucky. So Carrie has also received numerous awards within the pharmacy profession, including one that I think she's super proud of, which is the 2014 Virginia Pharmacists Association Excellence in Innovation Award. She's also done a lot of educational work in the area that we're going to be talking about today on the pharmacist care process and training student pharmacists and residents on comprehensive medication management and integrating that into the primary care setting. So before we get started on this interesting topic, I am going to imagine that a few of you may not know who MCARA Health is in relation to Pop Healthcare. So I thought I'd give you a very brief overview before we get into the meat of the conversation with Carrie. So MCARA Health was born out of Pop Healthcare, as you might well imagine. Pop Healthcare has a long history in risk analytics and risk adjustment. So we have this kind of beautiful legacy of that end of the business. Then we also got into in-home health assessments. And through that experience with Pop Healthcare, we realized, there's more work that needs to be done for patients and members out there. So about 9 years ago, we launched in-home advanced primary care under the Pop Healthcare name. And then in 2021, we rebranded our advanced primary care practice under the MCARA Health name. So just a little bit of background there, as I think sometimes people are like, who's MCARA in relation to Pop Healthcare? So at the core of MCARA, we bring advanced primary care, behavioral health care, and connection to social resources to people really wherever they are. So this care can be in the form of, that annual visit that I mentioned earlier. It can be, transition of care from a facility like a hospital back to home or wherever a person calls home. It can be also just in a place where it's just hard to get access to care. And then certainly we work with people who are more frail, more medically complex, but who wish to be cared for and be able to stay at home. Through all of these things, even though we do a specialty kind of area in SDOH interventions, we actually do social determinant of health assessment intervention throughout all of our services. So in terms of the care that we deliver, we like to think of ourselves in terms of care traffic control. So if you think about all the things that a person might need to stay healthy, we do about 2/3 of the care continuum in the home or wherever a person resides. So we make it pretty easy to kind of adjust and modularize offerings. And you will notice kind of that one of the things that we provide is actually comprehensive medication management, medication reconciliation in that area. And that's the piece that we'll be talking about today. If you have any additional questions about MCARA Health or how we might be able to help you extend care to your most vulnerable, kind of hard to reach patients, please reach out and we'd be happy to have a conversation with you about that. But for now, we will turn our full attention to learning more about comprehensive medication management. And I'm going to stop sharing so that you can actually see Carrie's face in addition to mine. All right, so let's get started. So Carrie, since not all of us might be as familiar with comprehensive medication management as you are, I wonder if you can start by telling us just a little bit about CMM, kind of what it is and perhaps what it isn't.
Sure. So first of all, good afternoon, everybody. Thank you for joining today's call. So comprehensive medication management is defined by GTMRX, which is Get the Medications Right, from McInnes, Webb, and Strand back in 2012. And the definition is the standard of care that ensures each patient's medications, whether they're prescription, non-prescription, alternative, traditional, vitamins, or nutritional supplements, are individually assessed to determine that each medication is appropriate for the patient, effective for the medical condition, safe given the comorbidities and other medications being taken, and are able to be taken by the patient as intended. So essentially, when we think about CMM, it's a process of care for providing to the patient that focuses on the medication, how they're taking it comprehensively, and assessing that it is effective, it's safe, and it's optimized for their specific condition. That process of care is defined in CMM during 4 different pillars. So the first one is for assessment of the patient. The second is an evaluation of the medication therapy. The third is the development and implementation of an individualized medication plan. And then the fourth is follow-up and medication monitoring. So one of the big key pieces that to think about for CMM is that closing the gap and closing that loop to make sure that that medication is getting the appropriate monitoring it needs and that patient is being appropriately followed up with in a different consistency or relevancy depending on the medical condition that they have and how they're taking the medication.
That's great. I know you and I have talked about some of these things. There are numerous papers that have been written out there on the topic of CMM and the importance of developing frameworks to integrate into care delivery. Why do you, I guess, personally think that CMM is so important?
Most of the things to consider is that medications are included in about 80% of all Western treatment plans. So more than likely, if you go to a practitioner's office, you're going to get started on a medication. And the older you are, or the more medical conditions you are, the higher the number of medications that you're taking. So there's a higher risk of safety events. There's a higher risk of having inadequate response to the medication, or there's some other piece that pops up for that medication itself. When you look at some of the dispensing data in 2021, there were about 5 billion prescriptions dispensed in that year. They are anticipating another 1 billion in the next 10 years. So it's just going to continue to increase given the number of medications that are being taken by different people for various conditions. The folks who are higher likelihood of benefiting from the CMM care process are those that are on a significant more number of meds and a higher increase of medical conditions. One of the other things that I look for as I think about CMM is it improves the safety as well as the quality of life for patients. So that's taking a deeper look at how are they taking it, why are they taking it, make sure they understand how to take it. A lot of times when you think through CMM, it is a full process to understand and meet the patient where they are and be able to continue them on that and handle it safely. So one of the other pieces, since we're doing that on a tailored basis, a patient example that I get very, very often throughout my career is insulin specifically. Patients can sometimes be very scared to take insulin because of the side effects, because of the injections. And it's trying to determine what's the root cause of why. Why are they resistant to it? Why are they having issues? What's kind of going on in the background? A lot of that is using motivational interview techniques. It's using other avenues to be able to get them to kind of open up and start having that dialogue as to why that could be. Trying an alternative up front that may be more beneficial for them. And then trying to work through, is it a side effect issue? Is there a concern for safety? And then how do we address that going forward? I used to get a lot of referrals because patients said, oh, they're not going to take insulin at all. And so by the time they come to me after a couple of different sessions, we're getting them on insulin, getting them started and lowering their A1C.
Excellent. Yeah, you have great stories. I love getting all the stories from your career about working with patients. I guess, getting more into primary care and really talking about comprehensive medication management. Why, kind of beyond the scope of comprehensive medication management generally, why is it so important that we get this into the primary care setting?
So I'm actually going to use a football analogy. Primary care is essentially the quarterback of that patient's care. They're the one helping with coordination. They're the one who are acting as that point of reference to get all the different information. The other thing is that you can have gaps occurring when you have patients with these multiple chronic conditions and they're seeing multiple different practitioners, specialists for a variety of different reasons. And primary care kind of brings that all together. And the CMM process can help tailor that to make sure that you're meeting the patient where they have with all the different providers that they have and helping with that coordination in the primary care setting. So an example would be that patient is seeing rheumatology specifically for a immune deficiency for various different conditions. They're prescribed a medication and that medication suppresses the immune system. Labs are generally needed for monitoring, recommendation, the start of therapy, et cetera. But sometimes vaccinations get missed. And so primary care can help with stepping in to meet that gap. But sometimes there is that disconnect. So utilizing the CMM process to make sure that that patient understands what they need to appropriately treat their condition, deal with the medication side effects that could be anticipated, and be proactive in managing their healthcare to be able to be more of a preventive aspect as well. So when I think about CMM, I think about not just medications that you might take or inject. I'm also thinking about the vaccinations of the patients that they need to keep them healthy.
That's great. Yeah, I didn't even think about that end of it with respect to vaccinations. And that's a super interesting and kind of scary story that you just shared. So I guess as we think about CMM, improving health equity is, of course, a huge goal in the delivery of advanced care now. How does integrating CMM with primary care move us closer to that goal?
So one of the things that I also think about CMM is it's assessing to make sure that the patient can obtain the medication that they need to treat their health condition, that they have the transportation, that they can pay for it, they can pick it up, they can work through those logistics. Some of the biggest barriers that you do see for non-adherence are because patients have one of those social determinants of health issues that relates to them not actually being able to pick it up and take it the way that it was prescribed. And so when we think about CMM and health equity, there are a huge opportunities to make sure that that helps to bridge that gap to understand what's kind of going on. I've seen cases where folks have refused to tell their practitioner that they can't afford something. And so it gets either to the pharmacy itself, or if there's a pharmacist integrated within that care, the patient is just not controlled, the practitioner is not sure what's going on. And then it gets to, as long as you have that integrated piece of the CMM framework, it drives into what's kind of going on in the background. And it turns out they weren't actually taking the medication to begin with. And so figuring out why, working through what that is, and helping them get the assistance they need, whether that's coordinating with a social worker on the team, whether that's coordinating with foundations to get coverage, whether that's coordinating with the health plan of what is on formulary, what's covered, what are our options and opportunities to help me get that person to understand what they need. I'm also going to give another patient example just because I think it brings it home. So there was a patient who's unable to afford a specific medication for rheumatoid arthritis. They're able to afford a different one because the copay structure is available to them and it wasn't an issue. But that one wasn't working. And the rheumatologist wanted them to take a different one. Well, the patient never filled it and said, I'm not doing it because we can't afford it. So their rheumatoid arthritis is going untreated and not optimized because there is that pay barrier that's there, and trying to understand how can we help them meet their coverage. Another example is unable to meet. You guys have heard in the news about insulin costs and insulin copays and the new legislation that came out about the Inflation Reduction Act that includes the cap on copays for insulin. But there's a lot of times where patients can't meet that copay and their blood sugar continues to increase, which causes an admission, which causes multiple other cascading events that could happen. And so making sure that we can optimize what options we have and have that patient be able to take it and be able to be empowered to understand the importance and meet them where they are. So that way they don't feel like they can't afford something just because it's this, helping them to realize that we are there as their support to get them where they need to be.
That's great. And I, again, love the examples that you provided here. So you definitely have all of this experience building frameworks and kind of successfully integrating into primary care. When you think about kind of health plans and providers collaborating together, what are your recommendations for how to collaborate to implement all of this?
So one of the things that I usually say is think outside the box, meaning think about other opportunities and ways that you can influence different pieces, whether that's collaboration with a group that wants to partner in a value-based structure arrangement to help to lower the total cost of care, improving quality, any of those different pieces, or partnering with people and other entities that experience building those programs, integrating into networks, and piloting with a project or specific group. Sometimes it could be a health system, a physician group, community pharmacies, chains, grocery stores, independently owned. There are opportunities to look at when it looks at partnership. One of a partnership that I've seen that's worked in the past is also with like Michigan Medicine and Blue Cross Blue Shield of Michigan. They were able to partner probably, I think it's about 10 years ago, on the pharmacist process of reducing overall cost of care and other different pieces. Another group that's done that very successfully in partnering with payers such as yourselves is Fairview Pharmacy Services in Minnesota. They have a huge CMM framework. They've used a consistent pharmacist process for many, many years. And so they partnered with various different entities to be able to expand what that is, what that looks like, and how can they influence the different areas around them.
Right. I guess it's more specific to the health plan audience. Is there anything beyond kind of value-based care and some of the other things that you mentioned that health plans can do to drive adoption of this sort of framework?
So there's typically, the way that I think through this is 3 different pieces. You've already mentioned the alternative payment model, so that value-based care structure that would incentivize providers and other practitioners to look into providing the CMM. It does take a little bit longer. And so when you also think about different pieces, it's payment for providing the service. For the benefit for there, because we still have a split fee for service and the value-based payment arrangements, because some places are still predominantly fee for service, these types of visits take longer. So it decreases the number of patients they can see and visits that they complete in a specific time frame. So payment for services has been something that several organizations have looked to do within the CMM piece to be able to make sure that it gets the attention that it needs. The third thing that I usually think about is pharmacist provider status. So pharmacists are uniquely have the expertise to provide CMM because of training, background, our focus specifically on the medications as we've gone through our careers and working in a team-based environment. But we're not recognized as providers under Medicare Part B, as in boy. And so there's a lot of different pieces that you do see on that space. A lot of pharmacists want to be able to step up, but they're lacking that fee for service ability to cover their services without that value-based payment, because most pharmacies don't have that type of structure unless they're part of an IDN or other different groups. And then there's various different pieces that you look at when you go through that modeling.
We've kind of been leading this direction, but since we are talking to, I think, primarily a health plan audience, I think we have to talk about both the aspects for the patient and then also kind of the return on investment and how does this help kind of health plans be more efficient too. So beyond the super important benefits of patient safety and improved health outcomes, what would you say or share with us about the ROI and the financial benefits to plan to support this sort of model?
Sure. So some of the data that's currently been gathered regarding the delivery of CMM shows an ROI as high as 12 to 1 with an average about 3 to 5 to 1. And that is typically when you pull some of the white papers that are going to be referenced here a little bit later as we walk through our reference options. That ROI comes from reducing hospital admissions, physician visits, ED, and inappropriate medication spend. So filling a medication when a patient doesn't actually need it, or because they weren't optimized taking one of their other meds, so you're eliminating that process. A couple of the other data does suggest that annually, CMM can help Medicare avoid about 6 million in physician visits and 670,000 ED visits, which is estimated to be about $1 billion and more than 500 million per year. It's understanding that. The other piece, this does not take into consideration or account for patients' improvement in quality of life, their satisfaction, or improving the quality metrics, such as your HEDIS and STAR ratings that you might see with in some of these plans. This is strictly a lower cost of care, total cost of care reduction when you look through CMM in that process.
That's great. Yeah, some of the numbers are really compelling when you look at the numbers overall, and some of the studies that you shared with me, I think, really show pretty remarkable ROI opportunities that are out there too. So I know you've put together a great list of resources that we can share out to the audience today. So if our audience is interested in learning more about CMM, I guess I would ask you, are there any particular ones that you would point them to? And I guess I should also say for the folks who are on the call that one of the things we'll be sharing along with this deck that we used earlier is a list of resources that Carrie has put together. It's pretty extensive. So if you're interested in learning more about CMM, then you'll have some good places to look. But Carrie, I just wanted to ask you if there are any places you would specifically point people kind of right out of the chute.
Sure. One of them I mentioned earlier when I referenced the definition. So get the medications right. So GTMRX. They have a robust footprint of what CMM is, some of the examples that are there, what that means and what that looks like. Some other groups that have are the PCPCC, And that's one of the references listed. There's several pharmacy organizations. So the American College of Clinical Pharmacy, American Society of Health System Pharmacists, and the American Pharmacists Association all have some form of process, either the patient care process or CMM, that outlines what those expectations are. A couple other organizations are optimizing medications for better health. And then the last one that I will mention is actually a journal article that you're going to see referenced from the American Board of Family Medicine.
Great, awesome. We do have a couple of additional questions, but before we go there, I wanted to make sure that if the audience has any questions, that they get an opportunity to ask or put those in the chat. So I'm looking at chat right now and I don't see anything out there. But if there are, please, please put those in for us. So before we kind of move forward, I guess I would ask you one question that maybe we haven't answered yet. And that is, we hear a lot about kind of medication therapy management, or MTM. How do you distinguish between MTM and CMM? Because I feel like I see them used interchangeably. And I think from our conversations, you said, no, actually, they're not interchangeable.
Yes. So MTM, or medication therapy management, is defined by CMS, so the Centers for Medicare and Medicaid. And it does not have a specific care process that's involved. Yes, there are required elements and components, and you have to complete a comprehensive medication review. The biggest piece is once the interventions are made, it doesn't have that same follow-up rigor that CMM does. So CMM includes that follow-up as it happens after the fact to make sure those recommendations are implemented, that it's being followed by the patient, and the patient doesn't have continued questions or conversations. The other things that I do typically mention with CMM is it's typically coupled with a pharmacist-provider collaborative agreement. And so what exactly is that? It's defined by each state, but it's essentially a collaborative practice agreement where the pharmacist is allowed to start, stop, modify, continue or discontinue medications, and monitor ordering labs and other different pieces as a collaborator under that practitioner. Some of those it's defined again by the state. It could be a physician, could be a nurse practitioner, could be a physician assistant, could be a clinical nurse specialist. It could be a variety of number of potential prescribers, but essentially it has a set framework that allows it to be coupled very nicely with CMM, because the pharmacist is able to make those adjustments in real time for those specific conditions, depending on what comes up from that CMM. And it allows that follow-up and other pieces to happen in that care process. CPAs are highly used depending on who you talk to and where you are in the various different states. From a pharmacist standpoint, I've been operating in and out of a CPA since 2012. So it just depends on what folks' comfort level is for that. The other piece that I look at is making sure you're tracking the CMM, the outcomes, the continuum of those interventions, and then making sure you have access to EMR, so the electronic medical record of the practitioner you're working with, as well as collaborating with the other healthcare providers and doing that follow-up that's needed.
That's great. And some of the things you've just said, I guess, does a pharmacist have to be part of a primary care team for CMM to be successful, or have you seen models where, it's a community-based pharmacist, that sort of thing? Like, how does it work?
So yes, I've actually seen models where it's not a pharmacist embedded within that or integrated within that physician practice setting. It also doesn't have to be a pharmacist. It can be someone who's been trained in the CMM care process to work through that same type of rigor as it relates to that medications. So I'm going to start there first, and then I will go into the second half. So there are some primary care first models, and for those that may not be aware, primary care first is an innovative practice model that was created by CMS, and it's an innovative primary care payment structure as it relates to payment for that physician practice for the Medicare beneficiaries. And so there are some sites in that primary care first framework that don't have a pharmacist specifically in their space. but they're utilizing that CMM framework and being able to see it using that value-based payment structure, meeting the quality indicators, and working through that aspect. There are folks outside of the integrated pharmacy space that may be in a community setting. I know I had told Tiffany that there's a site locally in the area where I live where that pharmacy has a collaborative agreement, and they're working with a multitude of different practitioners to help with that chronic disease management specifically. There are other states and other different independent groups and chain and community pharmacies that are in actually grocery store pharmacies that are starting to work into that space. There are other types of structures and different pieces that you do see. And as I mentioned, it is typically coupled with that collaborative agreement where you see from that CMM process. One of the other groups that would have it is a group called CPESN, which is a group of independent pharmacies that have collated together, and they've been working towards transition of care collaboration, different CMM care processes within their affiliated pharmacies. And they have a movement called Flip the Pharmacy that tries to get pharmacists and pharmacies within their network to think about things a little bit differently instead of working through what the pharmacist provides on the quality care side and that that patient-centered discussion and clinical interventions that can be made, and how does that look and what does that mean and what does that look like?
Excellent. All right. So before we conclude, I wanted to ask if there's anything else you want to make sure that people know on this topic that I know you're very passionate about.
So when I think through CMM, I think of it as a patient-centric, patient-tailored approach to medications. Some people are more sensitive to certain medications than others. Some have more allergies to medications than others. Sometimes there's complicating medications that you take over the counter, herbals, OTCs, supplements that just don't ever get added into the equation. So making sure that those are at the table and at the forefront are key. One of my most complex patients that I have seen was prescribed 10 meds, 10. They brought 3 big cardboard boxes full of herbals, OTCs, supplements, and nutrition, like nutrient supplements, nutraceuticals, in to the visit with me. And it ended up being over 200 in total. So it's sorting through what do you need, what can we get rid of, how do we simplify the complexity of what's kind of going on, and then working through that process. So it took us multiple visits to consolidate it down to about a year later, they were down to 5. Wow. And yep, so it's
that's impressive.
Working through what that might look like. So the other thing that I would say is making sure that with the CMM process is including anything you take, anything you insert, anything you apply. So if that is a eye drop over the counter, if that is a something that you have a cortisone injection that comes into your knee, if that is what are the things that you may not think about that is a medication that you may not think is a medication. So when I think about CMM, I'm thinking about it big picture, everything.
Wow, that's great. Well, Carrie, thank you so much for your time today and for answering all my questions. Ron, I don't believe we have any additional questions from the audience, so I am going to turn it back over to you to close things out.
Okay, thank you very much. I'd just like to remind everyone that the slide deck and recording will be posted on the ACAP website by tomorrow morning, so keep an eye out for that. Other than that, thanks everyone for your time, and thanks to Tiffany and Carrie for their time today. Thanks again, and stay safe.